Hello, welcome back to the Future of Dermatology podcast. This is Faranak Kamangar, and today we have a really fun Ask Me Anything episode. And our guest host is none other than Payton Smith, our wonderful SF Derm medical student. He, of course, is going through his medical school training, but is also doing currently a clinical research fellowship at the University of California, San Francisco, and is doing lots and lots of exciting projects. Payton, thanks for being here.
Thanks for having me, Dr. Kamangar. It's great to see you.
Yeah, so much fun. So Payton's basically going to ask me a bunch of questions, and we'll just go through and ask and talk about them. I will let you take it away.
Okay, thank you. So my first question is, I've been hearing a lot about patch testing. I've kind of, done some research, but just for the audience out there, can you kind of talk about what patch testing is? Who is it for? Someone comes into the clinic and you decide to patch test them. What might you be looking for? And just kind of describe the process if you can.
Oh, absolutely. That's a great question. Patch testing is something we should all probably be doing even more of. It is testing for type 4 type of allergies or contact allergies, basically things that come into contact with your skin. Usually items that you might have even been exposed to for even over time because your skin has become sensitized to it. So one thing we hear a lot from patients is, well, I couldn't possibly be allergic to that one thing because I've used it for years. But that's actually by definition, you sort of have to get exposed to something before, have a little bit of a built up T cells that will react when you see that antigen again. So basically, the contact dermatitis itself could present a little differently. There's like the classic rash we see with, let's say, like poison oak, where it's red and you get little blisters and all of that. But you could even get just mild itching, mild eczema type symptoms. So when patients come in with rash that just doesn't do what we want it to do, which is, treat with the medicine that we think would treat it, we have to start thinking about contact dermatitis. Or if it's just in like weird places that you're like, that something must have touched your skin there. Like, for example, like we're talking right now, we all have our earbuds set. If a patient came in and had a rash right around their earbud area, we're like, okay, maybe you have an allergy to your wearable. Or they come in and they have an allergy around their feet. We're like, okay, maybe it's the shoes or different things that the site is suggestive that it's actually something that your skin's touching. The ones like the rash on the face and things like that we can't figure out, those are difficult because there's so much stuff out there that we're putting on our skin, like shampoos, conditioners, moisturizers, sunscreens, cosmeceuticals, all the things. So there's so many more ingredients coming out that it's almost kind of hard to keep up with allergens now, I feel like, because there's so much stuff people are putting on their skin. But basically, to come back to patch test, technically what a patch test is, we put a bunch of little patches on your back and they contain different antigens in them. Different clinics might use different ones. There's like a true test is a common one, but it's not very comprehensive. So a lot of derm clinics will use the North American Contact Dermatitis series. That's a little more elaborate, tests like 80 plus antigens, and then you can add on to that. So let's say someone is like a dentist, you would add the dental tray for like common stuff you touch as a dentist. Or let's say you're worried about eyelid dermatitis, you want to add things like, and they dye their hair, you want to add like hair dye series. So you can add kind of extra patches. And we always have patients bring their own products in too. So if we're able to patch their own product, sometimes that's really helpful too. So we put a bunch of patches on your back. You can't wash it because there's like tapes keeping it in place. You can't wash that area for like a good 2 days. So usually we just do Monday, Wednesday, Friday visits in 1 week. They come in on a Monday, apply everything, can't shower from Monday to Wednesday. Wednesday, they come back, we take off the patches, and then we do the first read. So early on, you might be starting to show some reaction. Then they come back Friday, and we look for things that took all week to kind of show up. Then there are a couple late reactants. We don't schedule past Friday, but we always tell patients, like this spot, could take more than 7 days. So if you see something popping up next week, just let me know. Every once in a while, that happens too. So that's basically the gist of the patch test, to try to identify what you might be allergic to. That's sort of the first battle. If you don't have anything we find, maybe it's just intrinsic eczema, maybe it's irritant dermatitis. So it's not really an allergy, but so you're just putting on a ton of like, I don't know, I'm just going to make up a thing regimen here, but so you're putting a ton of glycolic acid every night or something. Little doses, that's fine, but high doses, maybe you're irritating yourself. or you might just have intrinsic genetic changes that kind of give you eczema. But let's say you do find some contact allergens, then we can give you lists. And the Contact Dermatitis Society is really great. They have a really good database. You can plug in the ingredients and it kind of gives you a safe list. It's a little hard, I have to admit, even at that stage when we find the positives, it's not always the easiest thing for patients because you have these like long names like you're allergic to like methylchloroisothiazolinone and like please go look for that and in your ingredients, and sometimes it's not called that, sometimes it's called Kathon. So like it's not the easiest for a patient, but it's a good start basically. And then it also kind of just confirms that, this is probably more allergy driven. Contact dermatitis, if caught early enough, you can maybe alter the course of it. But sometimes if you've allergic to something for a long time, even if you take away the allergen, the rash might still persist just because your skin has just learned to do that, the inflammatory cells. So it can become chronic. So it's really important to patch test early. And if there's allergens, just get rid of it. But hopefully that wasn't too long of an answer. But that's basically
No. So, okay, my follow-up question would be, I've been to the allergist before, and I think that they may have done maybe a similar test. Maybe it's called like a scratch test there, or what would you say is the difference between, the patch testing done by a dermatologist and the type of test that an allergist might do, if you're familiar with those other tests?
Great question. Allergists can do a wide variety of allergy tests. A lot of times they'll do type 1 hypersensitivity type testing to environmental allergens like grass, pollen, all that kind of stuff, animals, foods. So they do that type 1 type of testing. And they can do that via the RAS test or those skin prick tests. They can do it via blood as well, sometimes serum tests. Lots of allergists will actually also do type 4 allergy patch testing, but they're a little bit different. They're mediated a little bit differently. Like the type 4 is more like the T cell driven type of allergy, that kind of memory T cell, versus type 1 is more like IgE driven and just more of like a sensitivity. Both are important, and that you bring up a good point, because sometimes I'll ask patients, I'll say, have we done allergy testing? And they'll say, yeah, I've done that. But I'm like, okay, what did you actually do? Did you put stuff on like those little patches on your back? And they say, yeah, I did the thing on my back. I'm like, okay, but was it like a strip like this with little tiny dots and you come out of the days like Friday? Or was it like a little prick on your back? And they're like, oh yeah, the prick. So it's actually, I think patients think it's all kind of the same thing. Understandably, we're saying allergy testing, but there are kind of various types of allergies that you can have. Some allergists do patch testing thoroughly as well. Most might do like a true test, which is also not bad. Actually, that picks up a good amount, but it's not super complete. It might miss some allergens. So it might be good, especially if you feel like you have a strange allergy that you haven't figured out over years. It might be good to do it with the dermatology department, just because then we'll test you for everything. I know there's specific centers that really focus on patch testing. They'll go even the extra mile and they'll do all sorts of interesting things, like there's photo patch testing that we could like test you to even allergies to UVA, UVB. We could get all sorts of fancy with the different allergies that can happen.
Wow.
So I think it might, if you're having recalcitrant skin disease, can't figure it out, it's good to be plugged in with dermatology.
So moral of the story, go to your dermatologist for patch testing, go to your allergist for the prick testing. But that's good to know. Thank you so much for telling me about that. So then my second question would be about oral minoxidil for hair loss. I've kind of heard some stuff about it. I've heard some people say stay away from it. It could cause, like heart problems or blood pressure problems. Some people seem to say, oh, it's a cure for alopecia. What are your thoughts on oral minoxidil for hair loss?
Yeah, so oral minoxidil has been around for a very long time, but it's kind of gained celebrity status after a New York Times article, I think it was last year. So then everybody started coming to our clinic and asking for it. So it's not a novel therapy in any sort of way. It does help grow hair for sure. We do use it in clinic as well, especially a little more since patients ask for it. And we say, okay, that's reasonable, let's do it. It can have cardiovascular side effects. It is a blood pressure medicine, so it can drop your blood pressure. Usually there's certain instances where I just don't prescribe it. Like, for example, over age 70, history of cardiac events, arrhythmias, it's probably good not to mess with things too much. But if someone's young and healthy and they want to try it, we start low dose. We go maximum to about like 2.5 milligrams. Although for blood pressure and other things, primary care docs will go higher than that. But usually below 2.5 milligrams, the risks seem to be lower for having the heart problems, lower extremity edema. Lowering your blood pressure still can happen at lower than 2.5 milligrams just because it is a blood pressure medication. So we just have to be kind of careful about that. But it does work. It is efficacious. You'll get also maybe hair in places you don't want. That's maybe the downside of oral versus topical minoxidil. Topical minoxidil, of course, is Rogaine brand name, but lots of different brands have it now as well. Traditionally, it's been Rogaine. Lots of different brands have it. We usually recommend the 5% for everyone topically. And then there's, of course, compound pharmacies that make higher than 5% as well. There are lower than 5% formulations out there over the counter too, but 5% is pretty safe. So we usually just say if you're doing it, you might as well use the higher percent so it works a little bit better. But yeah, oral minoxidil is there for the right patient. Totally reasonable to take if they don't have any side effects to it or any like precautions.
Thank you. And then, so I've also heard a little bit about the topical minoxidil and finasteride combinations. Would you say that would be a safe treatment route to go down?
Yeah, absolutely. The topicals are pretty safe. They actually have a little bit less absorption into the body, so safer than taking things orally for sure. Minoxidil has been, when you go to compounding pharmacy, it's been mixed with different things like finasteride, sometimes topical spironolactone. Sometimes they'll throw a little bit of tretinoin in there, so it increases the absorption of all the other ingredients. The question of how much more those ingredients are adding to the minoxidil, I don't think we have a lot of great data to show that, oh yeah, it makes it way better to add this and that. So I think it's, starting with just minoxidil is probably good enough. And the main reason for that is the cost goes up as you add these things. So you can get 5% minoxidil pretty inexpensively now over the counter. And the thing is, you have to keep doing this for a really, really long time. So I think I would just pick the most kind of cost-effective way that works. Because when you go to compounding, it just makes each month's formula more expensive. The more stuff you add in there, it adds up too. Or if you're doing it every month for like years, I don't know how much more added benefit there is. But we use these things all the time. So our patients do prefer to like throw everything in there.
Thank you. Well, my next question has to do with a topic that I'm very passionate about and very interested in, and have some research coming out and hopefully very soon. But the topic of chronic itch for patients, what over-the-counter or prescription products are your favorite, do you think are the most efficacious for patients that struggle with chronic itch?
Yeah, that's a really good question. Chronic itch can be difficult. Sometimes it's difficult to kind of figure it out. There are different pathways to it. There's, of course, inflammation somewhere, whether it's in the skin or in the nerve endings. There's definitely an inflammatory piece. So there's always the anti-inflammatories like the topicals that we prescribe. Over the counter, you can't get too high of a strength of anti-inflammatories. So like you get hydrocortisone 1%, which might not be high enough. We could also try antihistamines, which sometimes work. But past that, I think the prescription anti-inflammatories can work a little bit better. As far as the skin barrier repair, that we should do regardless. So whatever is happening to your skin, wherever the itch is coming from or the inflammation, we know that inflammation, and if it's itchy enough or you're scratching, we know all of those things affect your skin barrier, meaning your just ability of your skin to kind of keep things out, not become irritated, and keep hydration is really important. So the over-the-counter products for hydration are pretty good. I would, of course, stay hydrated as well. Just drink lots of water and stay hydrated so that your dermis is staying plump and the hyaluronic acid in the dermis is holding on to as much water as it can. And then the epidermal layer, you want to use soaps and things that are not too harsh, where they're stripping your barrier, just really mild soaps in the shower, not super hot showers. And then when you're out of the shower, you want to just do a really good emollient to seal in moisture so you can repair your skin barrier as much as you can. That might not fix everything, but it's a good, and sometimes patients have said to me, I'm like suffering from this itch and you keep telling me to put on moisturizer. And sometimes it does seem like there is this disconnect for sure because every dermatologist says that. But like if we're not getting to the inflammation piece, they can put all the moisturizer they want, but they're still kind of irritated and waking up at night with itch. So I always explain to them it's not the only piece for sure. I totally understand that. It's not like a dismissing the itch and say, oh, just moisturize. But it really is an important, really super important part to keep the barrier intact. Because if the barrier is not intact, it's just going to make it worse. So over-the-counter things, there's lots of good emollients. There's lots of really good brands that we recommend with like ceramide. Some of those oat-containing ones can be a little bit anti-inflammatory. There's like CeraVe. Aveeno makes a really good itch relief balm, like eczema itch relief balm with oat that really kind of suits the skin. Cetaphil is another good one. The La Roche-Posay Lipicare one works really well too. So just ways to get the skin barrier in a back. But chronic itch is definitely multifactorial. So that another reason to see the dermatologist.
Absolutely. And can you kind of talk about, the difference between an emollient versus like a lotion, or, just some of those terms that maybe some of our viewers might not know the difference between?
Yeah, that's a really good point. So emollients are just kind of like a large bucket kind of category, but there are different things you can formulation. So there's lotions, there's creams, there's ointments. We generally recommend creams actually over lotions. Lotions mostly have water in the composition, so they feel a little bit nicer putting on. They're not super greasy, but they don't have a whole lot of the ingredients to add moisture to your skin. When you go to that's like usually the pumps are usually lotions, just so it can even come up the pump. Then when you go to the creams, which is usually like the jars that you have to open, the creams can start to feel a little oilier, but dry skin, and if you're really trying to repair your skin, you need creams or ointments. Creams are less greasy than ointment, so it's usually the go-to in between thing, and they just have a higher content of ceramides and other moisturizing ingredients rather than just being made up mostly of water. Ointments are usually really good and they're very occlusive, but then you probably don't want to like douse your entire body with like Vaseline or Aquaphor. But in hot spots, they work really well to seal off. But usually, a lot of times, if it's sort of like an Aquaphor Vaseline, it's more just barrier. It's not kind of driving a lot of hydration into the skin. So they put a cream underneath that kind of seal it in with an ointment. But it's true that, the vehicle of delivery does matter. Because sometimes patients I've been using lotion every single day and nothing's getting better, but maybe it wasn't, high enough concentration to actually moisturize your skin.
Yeah, I hate the feeling of a cream on my skin, but I hate the feeling of being itchy way more. So I just need to remind myself of that. Like, okay, this is not as bad as the alternative. So
it's not as, and then it does absorb into the skin quickly. It's usually like you might put something on and you're like, oh, that's way greasy, but your skin might just need it and your skin will just take it up and it won't be super greasy in a few minutes. So
yeah, like a sponge, it just soaks it right in.
yeah, exactly.
Okay, so this next question was submitted by one of my friends. She said she's been hearing a lot about argireline, if I'm saying that right. I think it's a peptide. So argireline, would you say it works, or would it be better to just use like tretinoin, or how would you include argireline into your skincare if you do?
Argireline versus tretinoin, and we're kind of talking about like Retin-A for wrinkle reduction is kind of a category we're definitely talking about. Argireline is interesting. It's a hexapeptide that mimics the effects of Botox. So it's like they're neurotoxins. They basically make it less likely for your muscles to make the movement that creates the wrinkles. So they're kind of working on the movement of the skin. Tretinoin, on the other hand, retinoic acid, increases collagen in the skin. So it basically kind of boosts collagen repair, normalizing the fibroblasts. So they kind of do different things, both targeting making wrinkles, because basically the collagen loss is what really creates the wrinkle, like the movements of the muscle you've been doing since you were a baby. Babies even do it more strongly. Like if they're hungry, they're like, and then you see the forehead muscles probably going stronger than any adult even does. But their skin doesn't wrinkle over because they have so much collagen and elastin and kind of goodies in their skin. And then at some point, you lose collagen every year. In the late 20s, the collagen gets light enough in the skin where with the same exact movement, now the skin folds over and starts creating the wrinkle. And then you get less and less collagen, so the wrinkles get deeper and deeper. So it's kind of a multifactorial. So you got to repair the collagen so your skin's not folding over as much. But then with the neurotoxins, you're just trying to knock out your muscles so you can't even make the movement. That wrinkles the
Yeah.
skin. So probably long explanation, but basically they work so differently that it's hard to put them head to head. But I would say, so argireline is a topical, so it has to get through the skin to work, which isn't, it's not very good at doing. A little bit gets through, but it's not as good as like botulinum toxin, like Botox or Dysport, where you literally are injecting it right where it needs to be. So if you were to compare like Botox to tretinoin, I would say do both because they kind of do different things, but I'd say Botox will probably get you there faster because it literally will just knock out your muscle completely. Argireline is different because it'll work a little bit, but it's not as good as injectable botulinum toxin. So that one is, I think, still, maybe I would pick tretinoin over that just because we know tretinoin is going to get into your skin. It's a smaller molecule. It'll do what we want it to do. Argireline might not get to your skin, and then it's also a less stable compound. So depending on what company you're getting it from, you don't really know kind of the concentrations you're getting versus botulinum toxin, which is like very regulated. We know exactly if we put in a few units, we know what'll happen. These topical hexapeptides or peptides in general has to do with their size, their manufacturing, how much is actually still there after like a month or two, how much of it is still active. So there's so many variables. Whereas tretinoin, I think most companies know how to make tretinoin pretty stable, in a stable condition now. So again, long answer, but in that argireline versus tret, I think tret wins.
Yeah, I think I would have to say that as well. My skincare is, make it as simple as possible. And usually if I'm like, after we get past maybe 3 or 4 steps, I'm like, I don't have time for this. So really, as long as I'm getting the tret, I'm like, I think my bases are covered with the tret, and then, maybe some moisturizers after that.
Oh, 100%. Yep. Moisturize, tret, and sunscreen. And you're pretty good.
Yeah, you can't go wrong with those.
Probably save the money that people spend on those other things. Just save it up and just get Botox a couple of times a year.
How much easier. So this next question, kind of similar to the topic of collagen production stimulation, but let's talk about microneedling. How often should you get microneedling done, if at all? And then what have you heard about at-home microneedling? Is it safe? Should we stay away from it?
Yeah, another great question. Microneedling is great. Basically, when you come into the office, what we do is we poke lots of little holes with these little needles in your skin. And as the little channels are healing, you build more collagen. So it's just like an in-office way of building collagen as well. So you have like your ways at home with the tretinoin, and then we have lots of ways in office like microneedling, lasers, radio frequency microneedling to kind of create a bit of heat and injury to the skin. So you create more collagen. Usually we recommend just doing it like every month for a few rounds and then maybe keeping it up every 3 to 6 months. Collagen building after a procedure can take a couple months or sometimes even up to like 3 to 6 months to see full improvement. So I wouldn't be like, oh, okay, just did a microneedling. Let's see how my skin's doing 2 days later. But it takes a while for collagen to get built. So after you've been doing these continuously, usually we recommend a series and then you'll kind of start to see things kicking in. At home is not a bad idea either. It's just a little bit less regulated. So when things are less regulated, it's hard to know. It could be a terrible device. It could be jagged edges that, cut your skin and cause scarring, hyperpigmentation, infections. Those things could happen. I'm sure most of the devices that are out there and they give you proper instruction, you follow it, are probably fine. But then it's just so unregulated versus the devices that we use in offices have so much regulation that goes into it. So that's the only disclaimer that I would make. And also they won't be, of course, nothing at home is as strong as we do in the office. So if they're kind of pricey, I think just save the money and go into the office for the procedure.
Gotcha. And then what does the recovery time period look like? Or like, am I going to go into work the next day looking kind of crazy, like super red and inflamed? What's the process there?
It's actually not too bad with microneedling. Usually we say like give it 2-3 days of no, huge events, but a lot of times even the next day, everyone's fine. Right after you do look kind of crazy because we poked lots of little holes in your face. And usually you put like a peptide gel on, or if we pair it with PRP, you have like literally parts of your own blood on your face. So there are right after there's a little craziness, but the next day it really doesn't look too bad. It's not super. It's not like an ablative laser where you're red for like a week.
That's good to hear. Okay, so maybe I can just schedule it on a Friday and then be good on Monday.
You'll be fine by Monday.
Okay, that's great.
But stop your tretinoin a week before.
Oh, okay, okay. I'll put that on my calendar. So then my last question is about scars. Also one of my friends had this question that she wanted me to send in, but scars that, haven't changed in over a year, maybe you forgot to put on your silicone sheets for a while, and then, you're still unhappy with the look of your scar. Is there anything that can be done about that? Or is it kind of like set in stone?
Yeah, no, it's never too late for scars. So there's all sorts of different scars. So you can have pigmented scars, which we can work on the pigment. If it's brown or red, we can work on that. If it's an atrophic scar, I mean, the scar is kind of like a divot. We can work on that to build collagen, to get it to fill in. If you have a hypertrophic scar, which is going the other way, it's like overgrown, thick scar, or at most a keloid, which is even like a thick scar, but even out of bounds of where the scar should be. Those we have ways to kind of shrink down the scar. So knowing there's lots of things you can do. At about a year, if you've been doing different things like silicone gel and different things at home, maybe those might be limited, but that might have a little bit less efficacy. Maybe just come in for the in-office procedures, but in-office with lots of things, you could do it anytime. There's no like it's too late, you missed the boat.
What type of in-office procedures would you recommend?
So we have all sorts of different ones. She brought up microneedling, which is a good one. We do a lot of that for atrophic acne scarring. You can do it for any type of scar that's a little bit atrophic. You kind of want it to fill in, like this a little bit indentation or unsmooth kind of texture. We can microneedle. We can go to even more intense lasers like a Fraxel or radio frequency, where we cause a little bit more heat with the damage to fill those in. Sometimes if it's like a really super deep scar, we'll even add a little bit of a chemical peel, like a trichloroacetic acid, to get that to fill in a bit more. And the other parts of the hypertrophic scars, we have lots of ways we can do too. Most common are little steroid injections we do to the thickened hypertrophic scars. But yeah, lots of different ways to kind of attack scars. So never too late.
That's good to hear. I'm sure my friend will be excited about that. But yeah, I think that's all the questions I had for today.
Those are awesome questions, Payton. Very, very fun. And then we always end the podcast, since it's the Future of Dermatology podcast, we always end it with if you're excited about anything for the future of dermatology. So anything you wanted to add about what you're excited about or things that you see might happen for the future.
Yeah, so there's many parts of dermatology that I'm very excited for and excited to see where future research takes us. But probably the most exciting thing for me as a patient right now would be the use of tofacitinib in patients that experience chronic idiopathic pruritus or just chronic itch. As a patient that struggles with that myself, seeing that possibly be FDA approved one day for patients like myself is very exciting, because at the moment we don't currently have any treatment that is FDA approved specifically for chronic idiopathic pruritus, or just patients that experience itch without any kind of rash or reason why they might be itching. So that's exciting for me, and then hopefully we might be able to further the research on that, and I hopefully would be a part of that one day. But yeah, so that's what I'm pretty excited for.
Yeah, I think it's so amazing when physicians also suffer from a condition. I think they just take the science so much further because you have that insight. And we were chatting, we should really do another episode where I'd love to kind of hear about your personal journey with this as well. So that's I think it's really important for that empathy piece, because you just are like living with something and you kind of understand the ins and outs. And we talk a lot about like shared medical decision making, which is that conversation between patient and a doctor. But what if like the physician had actually like lived a lot of that as well? So that makes it so much easier. And all of these new FDA approvals and indications are really great. They're making our lives so much easier to then ask insurance companies to cover medications that might help a patient. So really exciting things coming up.
Yeah.
But thank you so much, Peyton.